everyone, my name is Katie, and today I'm going to talk to you about Raynaud's phenomenon. This is under the patient care and APRA competency, and this is a legend containing all the acronyms you might need to refer back to. So what is Raynaud's phenomenon? So it's an extreme vascular response that discolors the affected area. And typically this discoloration follows a pattern. It'll be white to blue to red. So almost a blanching of the fingertips, and then blue, like they're not getting enough oxygen, and then red. Raynaud's event mainly affects fingers and toes, but it can affect other parts of the body, including the lips, nose, ears, and even the nipples. And it typically only affects one digit at first, then it can spread to the other digits. So if it's affecting your fingers, maybe it'll affect your ring or pinky finger first, and then move to your ring finger and your middle finger and your index, and so on and so forth. There are two types of Raynaud's phenomenon. Primary is going to be less severe and more common. It's idiopathic, so we don't know why it happens. Whereas secondary, and just like other disease states where secondary is a thing, there's usually either like an underlying disease or it can even be due to a medication, so it can be drug induced. And this is typically more severe, but maybe this is reversible possibly if we change the medication. So here's pathophys, and again, pathophys for MCQ is considered FYI, but it's important to know pathophysiology in pharmacy because it helps you realize why we treat things the way that we do. So basically what happens is we have this exaggerated vascular response that causes arteries to constrict. So there's a lot of vasoconstriction, and when there's vasoconstriction, there's limited blood flow, and if there's limited blood flow, we know there's limited oxygen. So this can last anywhere from seconds to hours. It depends on either how long the patient is outside, how severely it was they're getting impacted. And then there's this reactive hyperemia phase where blood flow rushes back into the fingers. So if you think about it, if you go outside, and we live in Canada, it can be quite cold in the winter. We go outside and get really, really, really cold, and you go back in, sometimes you can get very warm very quickly because your body's like, oh, thankfully I can, vasodilate. And that does happen in most people. In Raynaud's, though, it's a little bit more extreme. So here's kind of a diagram that shows you here. So we have our arteries that are carrying our blood, and you can see that these arteries aren't nice and go all the way up to our fingertips. But over here, it cuts off about the nail bed almost. And that's how we get this bluish tinge to our fingertips because there's no blood flow, so there's no oxygen. And we can also see that we have a wide open, nice, beautiful artery here, but over here, it's a lot more constricted. So our presentation here, patients have that color change, which is very characteristic. So again, white, blue, red, but they might also have throbbing, tingling, and burning sensation in the fingers themselves. It can start again in that one digit, and it can spread symmetrically in both hands. More severe cases can result in things like skin sores, even ulcerations, and it can lead to gangrene even. The clinical presentation and medical history is sufficient for diagnosis. There's not too many other conditions that can kind of cause this exact color changing pattern in this exact way. And usually, similar to some other diseases, symptoms usually actually decrease during pregnancy, they decrease in frequency and intensity during pregnancy. So there are a lot of conditions that actually do that as well, usually autoimmune disease conditions, and we'll talk in a minute, there might be a link there. So here are our risk factors. So unfortunately, it does impact females more. Family history is here. Being younger, also here. Living in a cold climate, so things like frostbite. This is important for us because we live in Canada, and I live in BC where it doesn't get too cold in the winter, but there are people that live very far north, people that even don't live far north, but it gets really cold and really snowy, and things like Manitoba and Saskatchewan and things like that. Repetitive damage to the arteries and nerves, so things like carpal tunnel. And I will say pharmacists are at an increased risk of carpal tunnel from opening those vials all day, right? Repetitive motions. So we also have occupational and recreational hazards. So some chemicals, so things like vinyl chloride, nicotine, so smokers, vinyl chloride frequently used for like hairstylists, vibration tools, so construction workers using jackhammers or power drills, and again, repetitive action, so pharmacists. I'm going to skip pharmacologic agents because we'll spend more time there since we are pharmacists, and then I'll go down here to medical conditions. This is also very interesting. So scleroderma is kind of a hardening of skin and other tissues. So blood might be harder to fully oxygenate depending on how thick the tissue is. You see a lot of autoimmune disease conditions here, right? Lupus, RA, Sjogren's, those three all can cause inflammation by nature of it being an autoimmune disease, and that inflammation can affect how our blood vessels actually work. Lupus and Sjogren's syndrome actually have a pretty high incidence of comorbid Raynaud's. Atherosclerosis, if we have kind of those narrowing, if our blood vessels, has these plaques already in it that already narrow it, that would make the condition worse should there be vasoconstriction. Hypothyroidism is an interesting one. Low thyroid hormone, and I'm going to write this one down because I think it's interesting. I got to write thyroid above this. Low thyroid hormone impairs vasculature. So it can lead to either, hypotension, hypertension, because it kind of messes with vasoconstriction and dilation. So if there's a vasoconstriction component to it, with like as in Raynaud's, you can see an increased incidence. And pulmonary hypertension as well kind of have that issue with vasodilation, vasoconstriction, but also patients with pulmonary hypertension aren't always able to oxygenate their blood as efficiently. So there might be less oxygen flow to the digits anyway. Our goals of therapy here, we want to minimize severity of signs and symptoms. If there's a secondary cause, we want to figure it out so we can correct it. We want to reduce and prevent the frequency of attacks, and of course, minimize adverse effects of drug therapy. So here are non-pharmacologic measures. And the most important one here is going to be avoiding triggers. So if I can get rid of a medication that might impact this, we're going to. So if we go back here, I told you we'd come back. So things like ergo derivatives. So these are frequently used in things like migraines because migraines are caused by kind of vasodilation. So these cause very potent vasoconstriction. Antineoplastics like bleomycin and cisplatin, interferon alpha and beta, which can be used in autoimmune disease conditions, stimulants. So this one's an important one, I would say, because it also plays into this younger demographic. It's patients are on things like Vyvanse or Adderall, so amphetamines, or things like methylphenidate-based stimulants, because we know that these cause vasoconstriction, and that's kind of our underlying theme here. Same with cyclosporine can cause vasoconstriction. And there is this thing out there saying beta blockers could cause this, but we know beta blockers, it might be due to kind of the compensatory mechanism, kind of, adjusting for the decreased heart rate with beta blockers, wanting to tighten up the blood vessels, but the evidence is kind of wishy-washy. So if I can stop one of those medications, I will. So if the patient is on cyclosporine, maybe we could do like a mycophenolic acid or a tacrolimus. If the patient is on one of the stimulants, maybe I don't need the full dose of stimulants. Lifestyle modifications, of course. Smoking cessation. We talked about nicotine being a vasoconstrictor, and we should always encourage smoking cessation in our smoking patients anyway. We want to reduce caffeine and alcohol, as always. Avoiding vibrating tools and repetitive motions at work to the best of their ability. And stress reduction. Managing temperature. So we want to reduce our exposure to the extremes, but especially the cold. So advising patients to stay indoors as much as they can during the very cold periods in winter. We want to make sure we're warming areas slowly if we need to. They should be wearing protective clothing, and this should be like kind of layers, right? So having a base layer, a coat, hat, scarf, even earmuffs, just covering as much exposed skin as they can. And then placing their hands or affected area under warm water. Warm, never hot water. It can cause burns. It can cause kind of swing the other way around because we already have reactive hyperemia, right? So putting your fingers in hot water at that point is not going to be a good idea. And then physical activity, you can try rotating your arms like a windmill. So like literally swinging them around because that helps kind of get the blood down further into the digits. Of note, do not use acupuncture. That's kind of listed every now and then. Don't use it. There's poor evidence. As far as pharmacologic measures go, we're looking at our dihydropyridine-based calcium channel blockers. So these are your DHPs. So this would not include verapamil and diltiazem because those are non-DHP. So we're looking at things like nifedipine. So side effects can be orthostatic hypotension. So we talk about syncope in another lecture, and that can increase risk of falls and all kinds of stuff. Headache and dizziness, flushing, tachycardia, which is a rare side effect with DHPs, and edema. And we know this is very common with things like amlodipine, and it's a common reason why patients end up discontinuing that medication. This is first line. And patients should take them about 30 to 60 minutes prior to going out in the cold. During the winter, they should be taking it daily. And this will just reduce the frequency, not necessarily the severity. So if they usually get it in 2 fingers, it's not going to take it down to 1 or none fingers. But instead of getting it every day they're outside, maybe they only get it once a week. So it's just kind of an overall improvement there. These are the alternatives, but this is FYI because these are just not used. The data is not there. Alpha blockers like prazosin, nitroglycerin, which is a skin ointment in this case. PDE5 inhibitors like sildenafil or tadalafil. Bosentan, which is usually used in like green preventative situations. Sympathectomy, which is a surgical method. ARBs like candesartan, and even SSRIs like fluoxetine. But overall, the DHP calcium channel blockers are the best that we've got right now. There's just not a lot of evidence for these. So these are, I'll put it at the top here, these are lacking evidence. So overall, most of our prevention is going to be non-pharmacologic, and then we can try an amlodipine or a nifedipine, something like that, if the patient would like. So here's our takeaway here. RAYNAUD is characterized by an extreme vascular response that has that discoloration, and again, it's white to blue to red. You can have pain and burning, tingling in the affected area, so it's called nerve pain symptoms, right? The clinical presentation and medical history is significant for that diagnosis. Primary and secondary respond to medications equally, very important to know. Primary may be managed with non-pharmacologic measures alone and is the mainstay therapy for pregnancy and breastfeeding. So non-pharms always pregnancy and breastfeeding, right? For first-line pharm therapy is going to be your DHP calcium channel blockers, so nifedipine or amlodipine most commonly. And daily medication administration will improve tolerance to side effects, and they should be taking daily in the winter, especially if they live in one of those super cold parts of Canada. So let's do a case. So with all my cases, as always, I'm going to highlight anything I think might be important down the line. So we have NS, a 28-year-old female presenting to the pharmacy for advice, who states that she was outside playing in the snow with her children when she noticed her right index finger turning white. She said that it later turned blue, but after a while it began burning and tingling and ultimately changed to red. Her past medical history is significant for ADHD and hypothyroidism. She's currently on lisdexamfetamine 30 milligrams and levothyroxine 125 micrograms daily. She does not smoke or drink, and she's currently avoiding caffeine while breastfeeding. So how many risk factors for RAYNAUD does NS have? Let's write them down. So she's female. And unfortunately, this is one that ladies are at a higher risk of. Less than 30 years old. She's on a stimulant because she's on lisdexamfetamine, which is Vyvanse. She has hypothyroidism. And we talked about that being kind of one of those interesting cases where the lower thyroid hormone actually leads to vascular changes. And she also lives in a cold environment. She lives somewhere it snows, so it's cold. So that's 5 total risk factors. Which of the following is not an appropriate counseling point for NS? I think I kind of said this a lot. I'll start at the bottom here. So warming the affected area slowly is a good counseling point. It should be done slowly. And we talked about rotating our arms like a windmill to increase blood flow back to the digits. Wearing protective clothing when she goes outside, yes. If she noticed her finger was turning white, she probably wasn't wearing gloves. So she needs to be wearing gloves if she's out in the snow. And then this is our answer here. Warm hands under hot water? No, it should not be hot water. It should be warm water would make that correct. And lastly, which of the following is the most appropriate treatment option for NS? This one's tricky. So we mentioned candesartan could possibly be, but it doesn't have some lacking evidence. And then diltiazem is one of those non-DHP calcium channel blockers. And we talked about how DHP calcium channel blockers are preferred for RAYNAUD. So you would think the answer would be A, right? No, this one's a tricky one. She's breastfeeding. She's breastfeeding. First line for pregnancy and breastfeeding is going to be non-pharmacologic measures. So avoiding a cold, using protective clothing, things like that. Should she stop breastfeeding and still is having issues with the non-pharmacologic measures, we could try amlodipine because that's a DHP calcium channel blocker. Since she's breastfeeding right now, our first line option will be pharmacologic measures. And that's it. Thank you guys so much.